Hey y'all, welcome back to my channel. If you haven't been here before, my name is Julie and I have a background in mental health, both professionally as well as personally. Today's video is for my Let's Get Clinical series where I go through the DSM and describe symptoms, prevalence, and treatment options for various mental health conditions. If you have not watched my series before, the DSM is this handy book right here. It is the Diagnostic and Statistical Manual of Mental Disorders. This is what clinicians, therapists, psychologists, etc. use to diagnose their clients with mental health conditions. Today's video is going to be on an eating disorder. This eating disorder is referred to as bulimia nervosa. I'm sure many of you know it as bulimia. In the DSM, clinically speaking, it's referred to as bulimia nervosa. So let's get into it. For diagnostic criteria, we have A, recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following. 1, eating in a discrete period of time within any 2-hour period, for example, an amount of food that's definitely larger than what most individuals would eat in a similar time period under similar circumstances. And 2, a sense of lack of control over eating during the episode, such as a feeling that one can't stop eating or control what or how much they are eating. So the first diagnostic criteria is specific to binge eating tendencies that are recurrent. B, recurrent inappropriate compensatory behaviors in order to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, or excessive exercise. C, the binge eating and inappropriate compensatory behaviors both occur on average at least once a week for 3 months. D, self-evaluation is unduly influenced by body shape and weight. E, the disturbance does not occur exclusively during episodes of anorexia nervosa. So the last criterion there differentiates that if these symptoms are occurring within anorexia nervosa, they are most likely going to be in that binge purge type diagnosis of anorexia as opposed to the diagnosis of bulimia nervosa. And also similar to anorexia, of course, within eating disorders and specifically bulimia nervosa here, we have that criterion about someone's preoccupation with their body shape and weight and them going to excessive measures and extremes to attempt to control that. Just like anorexia nervosa, if you watched my previous video on that, we have clinicians must specify whether the individual is in partial or full remission. In regard to specifying the severity of bulimia nervosa, the DSM states the minimum level of severity is based on the frequency of inappropriate compensatory behaviors, which were previously listed. The level of severity may be increased to reflect other symptoms and the degree of functional disability. Mild has to do with an average of 1 to 3 episodes of inappropriate compensatory behaviors per week. Moderate is an average of 4 to 7 episodes of inappropriate compensatory behaviors weekly. Severe is an average of 8 to 13 of these episodes, whereas extreme is an average of 14 or more. The DSM goes into further detail in the next section in which they describe that individuals with this mental health condition are typically ashamed of their eating problems and attempt to conceal their symptoms. Binge eating usually occurs in secrecy or as inconspicuously as possible. The binge eating typically continues till the individual is uncomfortably or even painfully full. Triggers of binge eating may include interpersonal stressors, so that means interacting with other individuals, a dietary restraint, negative feelings related to body weight, body shape, as well as food, or even boredom. Trigger warning here, I am getting into purging, and I know this can be very triggering as eating disorder symptoms in general can be triggered so easily and are very sensitive. So I don't want you to continue watching this if this is a disorder you may suffer from or if you struggle with purging, because I'm going to get into the specifics listed here regarding purging. Another feature of bulimia nervosa is these compensatory behaviors to prevent weight gain, such as purge behaviors or purging. Vomiting is the most common inappropriate compensatory behavior. I don't like the wording here because I don't want you to feel like, oh, I vomited, that's inappropriate, I should feel guilt and shame. No, you have a mental health condition that's very debilitating to have and you don't need to feel guilt for that because there is help. I just want to say that the DSM can be written in a very invalidating way, although the diagnoses themselves and prevalence are validating. Moving forward, vomiting can become a goal within itself because it tends to relieve physical discomfort and reduces the fear of gaining weight. So as we can can see, similarly to anorexia nervosa and other eating disorders, there is an OCD component within bulimia where someone has these obsessive thoughts and worries about gaining weight and then engages in these compensatory behaviors such as purging in order to reduce the obsessive thoughts. So they engage in a compulsion to reduce the obsession, which unfortunately perpetuates the obsession even if it minimizes the severity or persistence of the thoughts for a period of time. Other purging behaviors may include the misuse of laxatives as well as diuretics. The DSM also mentions that individuals with this mental health condition place an excessive emphasis on their body shape or weight when they're evaluating themselves, and this negatively, of course, can impact their self-esteem. Individuals with this disorder do have similarities to those with anorexia nervosa because they have an intensive, persistent fear of gaining weight, have a desire to lose weight, and feel generally dissatisfied with their bodies. For prevalence, according to the DSM, in 2013, the 12-month prevalence of bulimia nervosa among young females was 1 to 1.5%. Point prevalence is highest among young adults, since the disorder tends to peak in older adolescents as well as young adulthood. Less is known about this point prevalence of bulimia in males, but bulimia nervosa is far less common in males than it is in females, with an approximately 10 to 1 female to male ratio, which actually was the same for anorexia nervosa listed in the DSM, that men are less often diagnosed, but less is known about their condition. Thanks, society. Moving on. I also want to discuss some warning signs of bulimia nervosa that aren't specifically delineated in the DSM-V, although these can mean that an individual may be struggling with this disorder or may be at risk of developing it. They may skip meals or take small portions of food at regular meals. They may tend to disappear after eating and go to the bathroom. They may cut out entire food groups. They may fear eating in public or with others, similar to anorexia nervosa. They may steal or hoard food in strange places. And we know hoarding is an obsessive compulsive disorder, so again, this is how it ties in. They may drink excessive amounts of water or beverages without calories. They may use excessive amounts of mouthwash, mints, or gum. Similar to anorexia, they may hide their body with baggy clothes, maintain an excessive rigid exercise regimen that the purpose of it, instead of to be healthy and fit, is to burn calories that they consumed. They may have calluses on the back of their hands and knuckles from self-induced vomiting. Their teeth may be discolored or stained. Their lifestyle schedules or rituals may be created intentionally to make time for their binging and purging behaviors. They may withdraw socially. They may look bloated from fluid retention. They may go on frequent diets. They will tend to show extreme concern with body weight and shape. They may even frequently check themselves in the mirror for perceived flaws in their appearance. And they may also experience mood swings due to the severity of their condition. There are also some physical warning signs. We have noticeable weight fluctuations, both up and down. They may be overweight, but the body weight of an individual with this disorder is typically within a normal weight range. They may experience stomach cramps or other gastrointestinal issues such as constipation and acid reflux. They may have difficulties concentrating. They may deal with anemia, low thyroid or hormone levels, low potassium, low blood cell counts, as well as a slow heart rate. They may exhibit dizziness, fainting, or feeling cold all the time. They may endure sleep difficulties. They may have dental problems, dry skin, dry and brittle nails, fine hair on their body. Their hair on their head may be thinning or even become dry and brittle. This is referred to as lanugo. They may have cavities, muscle weakness, yellow skin, cold hands, menstrual irregularities, poor wound healing, and impaired immune functioning. They may struggle with co-occurring conditions as well, such as self-injury, substance abuse, impulsivity, and even diabulimia. There are dire health consequences to having bulimia nervosa and not having it treated in time as well, unfortunately. It can affect the entire digestive system. It can lead to electrolyte as well as chemical imbalances in the body that may affect the heart and other major organs functioning. The body tends to be resilient at coping with the stress of eating disorders, and laboratory results can even come back as perfect even when someone is at high risk of death. In regard to prevalence on the ANAD website, we have 1.5% of American women suffer from bulimia nervosa in their lifetime. Nearly half of bulimia patients have a comorbid mood disorder, more than half have comorbid anxiety disorders, and nearly 1 in 10 of bulimia patients have a comorbid substance abuse disorder, typically alcohol use. Finally, I'd like to briefly go over treatment. Depending on the severity of the mental health condition, the individual may need inpatient psychiatric hospitalization, especially if they're exhibiting suicidal tendencies or they don't feel safe on their own. They may benefit from a partial hospitalization where they go to an outpatient program and learn coping skills and receive counseling and resources, and then they go home at night and get to practice their skills. Also, outside of these treatment options, may benefit from residential as well as general psychotherapy. CBT has been shown to be fairly effective for eating disorders. However, from my research, I actually found that individuals with bulimia tend to have stronger results in their recovery from DBT instead of CBT. My belief on this is that bulimia nervosa is very comorbid with individuals who have borderline personality disorder and individuals who have BPD. The evidence-based treatment for them is DBT, so it makes sense that it would treat this disorder. Also, there are very high intense emotions within eating disorders, so DBT can be very helpful in allowing us to regulate these emotions through aspects in DBT such as emotion regulation as well as distress tolerance. Family therapy is extremely crucial for eating disorders, and I will get into that more in a separate video. I'm just briefly going over an overview of treatment options for this disorder. CBT is helpful, especially with the obsessive compulsive aspect of eating disorders, in that you tend to address thought processes, unpleasant or high intense emotions, as well as behaviors, how they're interrelated, and how you can address thoughts and beliefs and change them into something more neutral, which in time is theorized to help your emotional state as well as help to reduce these compulsions and compensatory behaviors. All right, that's all I have for you today. Thank you so much for watching. If you enjoyed this video, please give it a like. I'd love for you to subscribe to my channel as well. Please leave a comment down below letting me know if this was helpful for you and what mental health conditions you'd like to see me cover in the future. If you'd like to follow me on my social medias, my Instagram is Julie_counseling. My Twitter is JulieCounseling with no underscore, and my Facebook page will be linked down below as well. And I'll catch you on the flip side. Bye guys.